Alright, good morning everyone. Still awake? Anyone went to Mustafa last night? I heard there was a group of you at 4 a.m. making a lot of noise. Is that right? Not you, is it? I got a call from Mustafa. How many of you have visited Mustafa? It's really fascinating. Only you. Next time we should have a bus excursion. You can find anything under the sun, even aflibercept. But it's not cheaper, actually. Okay, so to follow on from Professor Takahashi's talk, so now we have, of course, several options. In the past, we didn't. We only had focal laser. And then we had PDT. And we had PDT with triamcinolone alone, and that was it. So for a long time, we were grappling with all these issues. We ended up with a lot of scarring. So the patient would come in and would say, Mr. Lim, your eye looks fantastic. And he says, no, I can't see. So what was good for the clinician was often not necessarily good for the patient. But I think now we have a little bit better information, we have more evidence. And I think we are able to manage visual acuity, management, maintenance a little bit better. Right? So let's look critically at what evidence we have. And we now have several randomized controlled trials, right, for PCV. Yesterday I talked to you about neovascular subtypes, right, and the importance of some of the imaging modalities. So, for example, if you are Caucasian, you are living in Europe, then the chance of finding polypoidal is probably very low, under 15%. Right? The majority, maybe about 2/3 of patients, will have underlying choroidal neovascularization. So it is reasonable in that context to assume that it is not polypoidal. And you only start thinking about polypoidal if you're not getting a response with anti-VEGF therapy, for example. You get a lot of hemorrhages, very unilateral disease. So these are the typical features where you would think about polypoidal. You will find that RAP constitutes about 10 to 20%, so quite significant. The older the patient, the more likely the RAP. And it's the same also in Asians, except that in Asians, the relative proportion is low, 5%, no more than 10% in most Asian students. Okay. But our problem is these two, 40%, even 50% maybe, so about half for Oriental Chinese. So Korean, Japan, Chinese origin will have this. We don't see this across the board in Asia. For example, our Indian colleagues, they see between 10 to 20%, so maybe somewhere in between. Yeah. In the Middle East, they are also around the same prevalence proportions as Europe. Interestingly, in Latin America and South America, they are reporting higher and higher rates of polypoidal. So probably it's a chicken and egg, right? If you don't do ICGA, you won't detect it. And if you detect it, you wouldn't treat it with anti-VEGF alone. Most times they will go to focal laser and so on. Recently, there was a paper published in Liverpool, so all Caucasian British patients, treatment naive, and about 30% of them had underlying polypoidal. So what is the true figure in Europe, we still don't know. But I think there is a distinct geographical difference, and that's probably genetically driven. We don't know, right? Probably genetic. And so clearly all the published data, you will find that varies quite a bit, but consistently Caucasian origin much less than Asian, especially Oriental descent. Okay. These are some more papers. If you look at Gabriel Costa's paper, what was interesting is he had two arms, one in France and the other was in Japan. So same study, same criteria, same diagnosis. And yet you will see very clearly 50% in Japanese patients, 9% in French Caucasian patients. So I think clearly there is that sort of difference. So the moment the patient walks in already, you are thinking, what is the profile of this? You've seen very nice pictures from Professor Takahashi. Right? In the past, we used to have to always do ICG. And we still do to confirm the diagnosis because OCT-A, for example, doesn't always pick it up. But the first thing that brings us to suspect underlying PCV is now often spectral domain OCT. And with spectral domain OCT, you're looking for a few very critical signs, almost hallmarks of underlying PCV. The first is this inverted V sign. Various descriptions have been proposed in the literature. I like the term thumb-like protrusion. So a thumb-like protrusion, very sharp inflection of the RPE separated from the Bruch's membrane, with or without fluid, with or without a PED. That's the first thing that sort of brings to mind. Maybe this is not typical choroidal neovascularization. And this is different from a serous PED. A serous PED is dome-shaped. It's convex and it's smooth at its apex. This one is sharp. Okay? So thumb-like protrusion of inverted V. And then you will see a split between the Bruch's membrane and the basement membrane of the RPE. This is not a true PED. A true PED is when actually there is a convex elevation of the RPE. Here is just an irregular undulation of the RPE line, and now you see the Bruch's line very distinctly different from the RPE line. So that separation is also very important. Of course, this is not unique to PCV. We see this in occult choroidal neovascularization too. It's in the same plane. And that has changed our concept of polypoidal. If you look at the initial illustrations by Rick Spade's group in the 1980s, they were thought to originate in the choriocapillaris. So the polyps, the branching vascular network, everything was in the choroid, not in the RPE. It was just pushing the RPE. RPE was the innocent bystander. But with spectral domain, we know it's not true. Every single case that we've looked at carefully is between the Bruch's membrane and the RPE. So it is a type of occult CNV. Do we call it CNV or not? I don't know. It's a discussion for another time. Some people say yes, it's a vasculopathy. Other people say no, it's just an anomaly. Whatever it is, the plane of involvement is sub-RPE above the Bruch's membrane. Okay? And that's very, very important. Because if you see pathology above the RPE, unlikely to be polypoidal unless you've got secondary process like choroidal neovascularization. You can get classic CNV. If it is in the choroid, maybe it's a tumor, maybe it's not polypoidal. Okay? So I think these two features together are probably what triggers a suspicion of underlying PCV. And the third important supporting actor, you know, in every movie you've got the lead actor, thumb-like protrusion, the lead actress, which is the branching vascular network, usually more important than the lead actor. And then the supporting cast, which is a choroid. Why? What is different about choroid between choroidal neovascularization in AMD and PCV in AMD is the thickness of the choroid. So when I'm not sure, I look at the choroid. If the choroid is very thin, even thinner than the entire retinal thickness, think again. It may not be PCV. Maybe it's just a vascularized PED, maybe it's just choroidal neovascularization. But when you have a choroid that is thicker than the entire thickness of the retina, and when you have these large dilated spaces, we call them pachyvessels, with less stroma but more vascular dilatation, so what we understand by pachychoroid, then the likelihood is that this might be PCV that we're dealing with rather than CNV. Is a very useful discriminator. And on a practical level, if the choroid is very thin, you really don't want to consider too much PDT, right? The more PDT you do, the more choroidal thinning, the more RPE atrophy there will be. So it does have a practical clinical significance. So when you are considering treatment of PCV, you don't just look at the polyp and the structure, you also look at the underlying structures. Can it withstand PDT? Let's say the patient has had 3 PDTs in the past. RPE looks healthy, but the choroid is very thin. Even if you are very sure there's polypoidal, you would think very, very carefully about repeating PDT over and over. So just bear in mind that the choroid despite being a supporting actor, is very, very crucial in prognosis. You have seen these pictures, and this illustrates beautifully in one slide all the important features of PCV: the thumb-like protrusion, the double layer sign, and the thick choroid with the dilated vessels called pachyvessels. Recognize this. If you see these features on the spectral domain OCT, start to consider underlying PCV. FFA doesn't show it, it's usually occult. And this is the time when you would order an ICG. The most specific OCT signs in this study in 2016 was the double layer sign and the thumb-like protrusion with a pigment epithelial detachment. So when you have this combination, okay, PCV is possible and maybe likely. I showed you the dilated vessels. Now sometimes the absolute thickness is difficult to determine. Right? There is no absolute normal for the choroid. Neither is there an absolute normal for the vessel diameter. So in a way, it's very subjective. I think AI will slowly look at maybe large bodies of data and then analyze what are the standard deviations. But until then, we only have a sort of guesstimate, you can call it. But in many studies, clearly, when you have PCV, the choroid is thicker than in choroidal neovascularization. So that's what I just want to emphasize. Look at the choroid cavity. You heard from Professor Takahashi, also Colin Tan yesterday, on the role of OCT-Angiography. This will improve with time. There are many companies looking at slow flow logarithms, algorithms looking at how we can vary the flow to try and catch it. What is more interesting is what Professor Takahashi just said. Why is it slow flow? Slow flow may be chronic, may be more deposits of intralesional fibrin or hyaline material. And maybe that will be an important biomarker. There might be a threshold of flow. That is, let's say the OCT-A can be manipulated. We can have high flow sequencing, and we can have low flow sequencing, and then we can use the OCT-A then to distinguish between high flow and low flow polyps. The analogy I use is a riverbed. High flow, water just goes through. And as sediment and silt gets deposited and laid down, then slow flow. The flow goes within. There's a lot of eddy currents and mud and sludge and lots of rubbish in it. Right? And so maybe that will be, in a way, a distinguishing biomarker of the future. It will wait for authorities like Professor Takahashi to guide us on whether that has a direct implication on the treatment that we choose. At the moment, we can't use OCT definitively because in some studies, sensitivity for picking up polyps is only 50%. Yes, in very experienced, very good centers, you can have 75, even 80%. But on average, the average patient getting it done in the clinic, maybe 50, 60%. So currently, ICG is still the gold standard for diagnosis. Even if you want to make a diagnosis and then decide to treatment, I think you still need a baseline ICG. I think you're familiar with the Everest diagnostic criteria. Did Professor Tan go through this already? Yeah. Just to go through it, the main one is early focal nodular subretinal ICGA hyperfluorescence. So memorize it. It's very simple. First 5 to 6 minutes. And therefore, when you ask for an angiogram, you should be in the room to watch the first minute at least. You start to see the branching vascular network. You look for pulsatility here. Pulsatile filling, which is rare, but once you see it, it's unmistakable. It's pathognomonic or PCV. Right? And then later you can come back and look at the data frames, 15 minutes, 20 minutes, 30 minutes. This is the early nodular hyperfluorescence. Nodular because it must be done exterior. It is beneath the RPE, so it's pushing the RPE up. And you would like to see this halo, hypofluorescent halo. And that is because the wall takes time for ICG dye to stain. So the dye is in the cavity, in the core. And only after 15-20 minutes does it actually get into the wall of the polyp. And then at the end, you actually have a reversal, right? You have retention of ICG dye in the wall, emptying of dye from the polyp itself. So if you see these two features, absolutely sure that this is wrong. So sometimes from a reading center point of view, it's very difficult to be absolutely sure. In Everest, of course, our aim was to be absolutely sure. So there were many that we turned away actually who had polypoidal, but they just did not have that 100% certainty that we needed for them to have polypoidal. In fact, it was a source of many angry calls from centers who said, why is my case rejected? I'm just showing here what pulsatility is. You need a video angiogram system, right? So this is the high-level spectral. This is one advantage of video angiography over flash angiography. It doesn't occur commonly, 10%, and I think these, almost all of them are actually high flow. Primarily, we think it's arterial, and they have a high propensity for bleeding. And that's why we pay attention to them. So hemorrhage is a problem with pulsatile models. So this question is important for people who don't routinely do ICGA. Right? I don't expect every patient to come in and get ICGA. So the features that I've highlighted would make you suspect that there's PCV, and certainly you would want to get an ICGA if these features are present. Orange nodules, massive hemorrhage, large hemorrhagic PEDs, and this is consistent even in non-Asian. Right? So if you have a Caucasian patient, large hemorrhagic PED, there is an 80% chance that there's underlying PCV in a Caucasian patient. Right? Notch PED, maybe not, right? You can have vascularized PED. Chronic CSC, think about underlying PCV. Absence of large soft drusen, and now a new entity known as Pachydrusen. Right? I'll show you what they look like. They're different from hard drusen, they're different from soft drusen. Younger age group, unilateral disease, again atypical, right, of AMD. And the last one, I think, is the most common scenario, where we're given 3 monthly injections, 6 monthly injections of an anti-VEGF, you don't see any response. I think you're familiar by now, all the clinical manifestations. So just to highlight that there is a myriad of ways patients with PCV can present, and they can present differently at different phases of evolution of disease. In the early stage, maybe they look like CSC. Later stage, they start to bleed, or maybe the nodules appear later. So it can morph from one to another, and that makes it challenging. I mentioned Pachydrusen. They are sharply demarcated, irregular margins, bizarre shaped, and usually with an underlying pachychoroid. So the pachychoroid looks like this tessellated orange fundus. They are not confluent. You can see that they are scattered and quite discrete, as opposed to the typical soft drusen, which are large, they are creamy, and they tend to join up together. Okay? So these are Pachydrusen. If you want to read more, look up Rick's seminal paper, 2018. It's just a comparison between soft drusen, tend to be confluent, tend to come towards the center, and Pachydrusen, which can be scattered all the way. I didn't realize this until, because we were describing this as intermediate drusen, we didn't know how to label it. Then when we started to talk as sort of specialist groups coming together, and we started looking at Pachydrusen, which is more common than you think. So go back, look at your fundus pictures, look at your clinical pictures. Okay? Pachydrusen does not mean they have polypoidal. Does not mean that. It just means that their choroid is probably thicker. And this is the choroidal thickness associated with Pachydrusen, significantly thicker than hard drusen or soft drusen. Now I talked about anti-VEGF non-response. In the early days, we already knew that anti-VEGF was very effective for choroidal neovascularization, but not always effective for PCV. So these are just some studies. Lin Tong Han also published some. Okaya's paper was interesting because of 102 eyes with early poor anti-VEGF response, after 3 initial injections, no morphological change, right? That means fluid remained the same. They found 56% to have underlying PCV. Now, it may vary from population to population. But the bottom line is, if you do not see any morphological change after 3 and certainly after 6 injections, I think an ICG is fairly mandatory, at least in our part. This is a 69-year-old initially treated with ranibizumab monotherapy. You see a single polyp, neurosensory fluid, no blood. 3 months after monthly injections, vision is still pretty good, but you can see that the polyps have doubled. There has been no effect. In fact, the fluid has increased a little bit, and the vision may be slid by a line. So this might be a response that you say, no early response to anti-VEGF. Maybe if you give another 3, you will settle. And remember, we talked about how in some places we don't even see patients in the 2nd and the 3rd month, right? They come in, get an assessment, they are scheduled for 3 injections at monthly intervals, and you don't see their response in between. I think that's wrong, because it is very instructive for us to see at each visit what is the reaction to what we've given them, right? It could be an adverse reaction, let's say a lot of inflammation. It could be a very good reaction or something like this, no reaction. So typical cases would be those that require 10, 12 injections in a year. Yes, you can control the fluid, but very often it doesn't completely go away. And the moment you try and stop, the fluid comes right back. So would you say it's resistant? Maybe not, but they're certainly not responding in the way that you want. In fact, you look across the data, Everest 2, Dragon, Planet, Aurora, it's quite clear that if you use just an anti-VEGF agent, any anti-VEGF agent, you're looking at 8 injections or more in a year. That's fine. If you're able to dry the retina, keep vision good, you prevent hemorrhage, and the patient's willing to come back often for injections. That is a reasonable approach. It's not that it's wrong. But certainly the number of injections gives the game away. That if you have the need for such numbers of injections, then think a little bit about PCV. So the options that we have now depend on the location. Sorry. Extrafoveal, juxtafoveal, we're still looking at ablative therapy. So focal laser photocoagulation, cheap and good. Very often I combine it now with an anti-VEGF because you want to reduce exudation as quickly as possible, and maybe you want to control the leakage from branching vascular network, right? Because focal laser is not going to do that. Focal laser will just ablate the polypoidal lesion. You can't end up with a huge scotoma, right? So very rarely now do we have this, right? I mean, most PCVs is actually macular. If you look at the Western series, especially in Afro-Caribbeans, it tends to be peripapillary. Europeans, Caucasians, somewhere in between. They have some peripapillary, mostly macular, but Afro-Caribbeans have this propensity for peripapillary lesions. Now, peripapillary lesions can be on the nasal side, so why do you want to use PDT? Just use focal laser, right? Those on the temporal side of the disc, along the papillomacular bundle, you have an option. You can ablate it lightly. You don't need to burn it so badly that you destroy the PM bundle. That works. Or you could do PDT to close the polyps. So these are all quite clear-cut. I think most people are in agreement. Extramacular, those in the periphery, you've heard of peripheral exudative hemorrhagic detachments. All those usually focal laser will do the job. When it's near the fovea, juxtafoveal, or subfoveal, of course, we have to think about anti-VEGF monotherapy. I would not do PDT monotherapy in this day and age when there's underlying PCV, mainly because of the long-term control of the branching vascular network. I'll talk a little bit about PDT monotherapy. And then, of course, you have combination. So essentially, it's a choice between monotherapy and combination therapy. Anti-VEGF first, and then maybe add PDT later. We call it deferred PDT. Either in a rescue, that means those who really cannot respond, then we add PDT, or it is planned. That means you start off with anti-VEGF and you plan to do combination therapy. Okay, so all these are sort of different permutations, different ways to skin a cat. Focal laser is very effective, as I said. You don't need to give a chalky burn as an outcome, right? In choroidal neovascularization, you have to burn it till it disappears. And then you end up, of course, with a deep scar, deep scotoma. Luckily, with polypoidal, a moderate burn is sufficient. So with a moderate burn, you'll find that the polyps will disappear very nicely and almost never come back on the same location. The problem is, they tend to come back in a different location. The main reason being you have not ablated the branching vascular network. So you think of the branching vascular network as the fingers of your hand, and the polyps are these little terminal bulbs. Right? If I close one polyp, I've just diverted the flow to the second finger. I follow that one, I burn that one, it goes on to the fourth finger, and so on. So basically, you're going to chase, right? And the recurrence rates are almost 50%. The current level evidence, we're lucky really that we have so many nice studies. Right? And in a way, we're grateful to companies like Bayer and Novartis who have invested, in these studies, because without these studies, it doesn't really tell us or give us a good evidence basis for what we do. Combination therapy, largely through the Everest program and Fujisan. Anti-VEGF monotherapy, PLANET used aflibercept, Dragon used randomized. So very good level 1 evidence studying the effects of these two major types of drugs. So let's first look at anti-VEGF. So just using an injection to control the disease. The PLANET study, multicenter, you see quite a few countries, two of them from Europe, Germany and Hungary, but the rest all from Asia Pacific. The primary endpoint was at 1 year, so week 52. Study design is very simple. Over 300 patients recruited, 3 loading doses. At 3 months, we decide whether they are randomized to PDT eligible or PDT sham. It doesn't mean that all these patients receive PDT, but they could receive PDT if needed. And I'll tell you what were the criteria. So half randomized here, half randomized there, and then week 52. The second year is very interesting because the second year was aflibercept treat and extend. Actually, this is the only study that tells us treat and extend in this fashion. The Altair study is the other from Japan, and so increasingly we are beginning to have data coming out from treat and extend. Okay. But let's look firstly at the first year. For those who were eligible for rescue PDT, that means on the first arm, you had to satisfy quite strict criteria. Why? Because the investigators believe that as long as you gave aflibercept, you wouldn't need to use PDT. We only use PDT when it's really a very dangerous situation or we really could not control it with aflibercept. So the aim was not to look at combination therapy actually, right? It was to validate the aflibercept monotherapy, but with the safety of having PDT. And I think the IRBs like that. The ethics boards were comfortable having a backup, right? But the primary aim was really not to look at combination. So here you see that the bar for PDT is deliberately set quite high. But that was an important part of the study. You had to be 6'12" or less. You had to have poor vision gain, less than 5 letters or between 5 and 10. OCT had to have new or persistent fluid, and there had to be evidence of active polyps. Active polyps means that the investigator felt that the ICGA matched the clinical presence of fluid. Okay. And then rescue therapy was needed. So you find that actually at the end of study, 52 weeks, 13% required rescue PDT. Not surprising. Right? And at the end of the entire study, only 17%. So if you choose an anti-VEGF monotherapy pathway with rescue PDT criteria similar to PLANET, you will need PDT less than 1/5 of the time. Right? So you can tell patients that maybe about 20% at the end of 2 years may require PDT to help control the disease, but most of the time you don't need it. And the visual acuity results confirm it. Right? Whether you add PDT or you don't add PDT, as long as you had aflibercept monotherapy at primary endpoint and at end of study, spectacular results. More than plus 10 letters. Anything above plus 5 letters is actually very respectable. So this is very good. Plus 10 letters, plus 11 letters. And it held in the second year with a treat and extend regimen. That means we can use a treat and extend regimen in the second year of PCV very safely. You don't lose vision at the end of it. And similarly, as you expect, very stable OCT. So once you dry the retina and the macula, it stays dry throughout the study. Provided you give 8 injections in the first year, which is their fixed dosing, there was no variation, so 8 injections. That means 3 initial monthly injections, followed by every 2 months, QA. First year, 8 injections. Second year, much less, right? Because second year, you are going to treat and extend. And in terms of controlling polyps, if you say, well, I see the polyp on the ICG, but there's no fluid, right? No fluid. So you could argue that these polyps are inactive. Just because you see them on ICG may not need treatment. Right? So there are 2 camps on this. One camp says, I don't want to see the ICG, or polyp on the ICG at all. I want it totally oblated, occluded, so that I can sleep more easily at night. Versus the other group who says, as long as they're inactive, what's the problem? I'm all right with watching them, right? So whichever you choose, as long as you know what it means, right? If you have polyps still present on ICG, they're not leaking, it means you have to monitor them quite closely because they could come back very quickly. So effectively, I think it's a case of monitoring burden. Because if you have polyps on the ICG, they're not active now. When are they going to be active? That's the key question. If you have destroyed the polyps have disappeared. You have a bit of breathing space. Of course, they could come back, right? They often do. But in general, it takes a bit of time before it starts to grow out into new polyps. So I think I'm in the latter camp, that I prefer not to see polyps if I can help it. All right? But not in every situation. So let's see. Over 24 months, you see that 8.1 injections in the first year, 4.6. So basically, in the treat and extend phase, your treatment burden is not that high. And because you're on treat and extend, your visit burden is also not that high. Yeah? So this is a reasonable option. I tell patients that you have these 2 approaches. These 2 have been validated, large-scale, well-conducted studies. If you choose injections alone, you have to be prepared to come in every month. 8 times in the first year, not every month. 8 times in the first year, fixed dosing. And then the second year, we can extend. Okay? And if you are prepared to do that, that's fine. The number of PDT administration was very low, as you say, it was 17% over 2 years. What about other agents? So Dragon was a study in China that looked at randomized monotherapy for neovascular AMD. So they had choroidal neovascularization and they had polypoidal. So 167 patients on monthly, 166 patients PRN, and they had quite a fair distribution of PCV versus non-PCV. You'll see that over 12 months and over 24 months, they had very good response to the monthly, right? Plus 12 letters. But then the patient had to come back monthly for 2 years and receive injection every time. May not be so palatable to most people. And in the PRN group, 9.4 9.4 letters, 9.7 and 2 years, not bad. In terms of the treatment burden, you can see that in the PRN group, it was very, very similar to aflibercept. So you can't really run away from this. Even with Avastin, you are seeing 8 to 9 injections. There is some homology actually with DME, right? In the afternoon, when we talk about diabetic macular edema, protocol I and protocol T show the same thing. In the first year, you're not going to get away with less than 8 injections. And that's the truth. It's a fact. And many clinicians are not telling their patients the facts. They're telling the patients 3 injections. They're telling the patients maybe 5 injections. They're not telling the patients that on average you need 8 injections. Okay. But clearly, you see with ranibizumab, it's the same thing. 8 injections in the first year. In the second year, 6 injections, a bit higher than efficacy, right? Because it's not on a treat and extend basis, but they come back every month for this. So obviously there are limitations. I mean, anti-VEGF is not for everybody. It's easy to administer, I understand that. So a lot of maybe general ophthalmologists who also treat retinal diseases, they tend to prefer monotherapy. Yeah? But frequent injections, high recurrence rates, 30 to 60% may be non-responders or poor responders. Maybe they respond a little bit, but don't completely resolve, and then once you stop treatment, it comes back. And the fact is, polypoidal lesions often persist. They don't disappear all the time. The exact frequency of complete occlusion varies with the study that you look at. But on average, any anti-VEGF agent will cause about 30%, 40% complete occlusion of polyps. And what is the problem with leaving these polyps, which may be inactive initially, but then become active later on, is hemorrhage. We are afraid of massive hemorrhage. PLANET, 33% had complete polyp regression. They were inactive, right? 80-90% of them did not show any form of activity at all. Yesterday we talked about activity, so the same criteria. But 33% still had 33% had complete closure on ICGA. 2/3 the polyps could still be seen. Right? And we see this also with ranibizumab, with bevacizumab. This is a patient from PLANET, 62-year-old. You can see a large PDT, and with 10 injections, so good response, 89 letters from 70 letters, so a plus 19 letters over 2 years. And then, after the study, he continued to be followed up in the clinic, right, but was no longer on regular efficacy outside the study. 4 months after his last injection, he had massive hemorrhage. So it can happen to anybody. It can happen even to patients who are after combination therapy. It is possible, right? And therefore, polypoidal is a very enigmatic disease, and in many ways much more challenging than choroidal neovascularization, because you have 2 problems to juggle in the air. You've got the problem of the polyps, active or non-active, hemorrhagic or non-hemorrhagic. You control that. And then you still have to control the BVN, the branching vascular network, which behaves like the occult CNV. Double the headache, actually. Right? This is a case of Lucentis. 4 Lucentis, 3 Eylea, macular, flat. Very good result. 6 weeks after that, sudden massive hemorrhage. Of course, it doesn't happen often. Right? If you look at the trial data, less than 10% hemorrhage any time during the 2 years. So as long as you're receiving anti-VEGF, don't stop. The moment you stop, you have to be very careful about recurrence. That's where combination therapy, I think, comes in. Right? Combination was part of Summit, so we had combination trying treatment for CNV. But we all know it didn't work, right? Nobody talked about combination therapy for occult CNV or predominantly classic CNV. Because, like in MONT BLANC, there was really no advantage in vision. There was no advantage in number of treatments. We thought PDT could reduce number of injections, it did not. So really, if you have occult CNV, classic CNV, that's not first choice. Right? So why PCV and not CNV? Why might it work? Because PCV is slightly different, I think. I'm going to talk a little bit more about this in APBRS actually, why PCV is different from CNV. But PCV has 2 components. Most CNV only have 1 component. The polyps and the BVN, which often then evolves to behave like choroidal neovascularization. PDT is more effective than anti-VEGF for polyp closure. That's not to say that the visual results are better. I'm just saying that if you want to close polyps and make them disappear, at least for a while, consistently, PDT is more effective. 30 to 60% may be refractory to anti-VEGF monotherapy. And you saw from Professor Takahashi's talk that choroidal thickness may play a role in the final prognosis. When we see vascular remodeling, choroid coming down in thickness in a pachychoroid case, it's actually a good sign, because you can link it to less leakage of ICG, so less ICG hyperpermeability, and hopefully less congestion and flow into the branching vascular network. That's conjecture, right? But there's good evidence to suggest that when you thin out the choroid from a pachychoroid to a normal choroid status, it is better overall for prevention of recurrences, control of activity. So I think that the choroid is the secret behind success in managing PCV. Just to recap, some of you might not have done PDT. Anyone here done PDT in your own practices? Very good. So I see a few hands. So you have first-hand experience with PDT. It's still a useful modality. People don't like it because it's very cumbersome, right? You have to put up a line, you have to have an infusion pump, and it occludes often. I don't know about you, but I used to have to try and clear occlusions often. Then they have these effects of backache, photosensitivity. It's really cumbersome. And you tell patients, well, you can't go outdoors for 2 days, and they say, my golf game is going to be affected and so on. So most people, if they had a choice, physicians included, would rather do an anti-VEGF injection. It takes a few seconds compared to half an hour in a room with the patient who's complaining about backache. So PDT has its drawbacks, it has its limitations. But the interesting thing is the mechanism of action. As you know, it targets upregulated LDLs. It's found in neovascular tissue, not just in the polyp, but also in the BBN, in some areas of the BBN. And when you apply PDT, you are inducing temporary endothelial damage, vascular thrombosis. So it's an angio-occlusive therapy. So it's a different mechanism. If you want to introduce a synergistic treatment, you don't want to use two things with the same mechanism of action. Right? You want to have different pathways, hopefully, hitting the same target. So that's what PDT does. Choroidal thickness has been shown to come down more with PDT than with aflibercept, and the least effective in choroidal change was ranibizumab. Everest 1 was the pilot study of combination therapy for polypoidal. 60 patients, 3 arms, because at that point we still had PDT monotherapy as a mainstay for a lot of our practices. And over 6 months, you see that complete polyp regression was about 2/3 or more, so over 70% when you had PDT. PDT monotherapy was 71%, combination therapy was 78%, compared to ranibizumab, less than 30%. So clearly, just adding PDT or PDT on its own was better at closing polyps. Not just inactivating them, but actually making them disappear on the ICG at 6 months. Now you may say that this is a very unusual study. Why is it that our focus was on the ICG? Because we wanted to prove that angio-occlusion could be achieved with combination therapy. And then Everest 2 went on to look at its functional outcome, visual outcome. Interestingly, we didn't really expect this. All 3 groups improved in vision, and although it's not statistically significant, you can see the p-values there, the trend was the highest visual gain in combination, then ranibizumab monotherapy, then PDT monotherapy. So in effect, PDT monotherapy achieved the least visual gains, and therefore most of us have moved away from PDT monotherapy. And this is also another problem. PDT itself can induce hemorrhage due to upregulation of VEGF. The transient ischemia following PDT is enough to cause a surge of VEGF in the local area and a recruitment of inflammatory factors and macrophages and cells. That causes this increased exudation. You see this with PDT, and sometimes hemorrhage. It's a bit like reactive hyperemia. Right? You tourniquet an arm, and then you release it easily. So the most critical point at which hemorrhage occurs, massive hemorrhage occurs, following PDT monotherapy, is about 1 to 2 weeks after treatment. That's when reactive hyperemia occurs, re-establishment of flow after the initial hypovolemia. When it's initially closed, it's fine, right? There's no flow to the area of treatment. I'm supposed to stop it. And so as it reperfuses, that's the time when you have to be careful, all right? And also with long-term PDT, this is full fluid, you see these lots of autofluorescence because RPE dies, either from the toxic effect of PDT or maybe from VEGF, repeated VEGF upregulation, I don't know. But certainly we know that the long-term results of PDT monotherapy are disappointing. From this pool data, at 3 years, very often PDT monotherapy does not give rise to visual gains. Long and short, we threw out PDT monotherapy as a first-line treatment for PCV, and went on to look at combination versus randomized monotherapy. These are the sites. And I think by now you know the study design was very simple. Combination versus monotherapy. And then at 12 months, depending on our results, they could switch combination if we could prove the combination was superior to monotherapy. So PRN, but all patients had to come back monthly over the 24 months. Visual acuity gains were better with combination versus randomized monotherapy. Very clear, right? Close to 10 letters in the combination versus 5 letters with monotherapy. Better outcomes across the board from the beginning, not just at the end. More gains, so 5 letter, 10 letter, 15 letter gains, all in favor of combination. Loss of vision was low in both arms. We thought that maybe if you add PDT with Lucentis, you might end up with more hemorrhage or more atrophy. But over 24 months, that was not so. And of course, polyp regression we knew from Everest 1. And so that was maintained, 70%, 56%, over 26% with ranibizumab, almost a doubling of the chance of complete polyp closure. And at month 3, if you had complete polyp closure, you had a 90% confidence that it will be closed at 6 months. Not bad, right? So another 3 months you bought. And at month 12, 80% continued to be closed. This is what I meant by buying time. Buying time because you know that as long as the polyps don't come back, you're relatively safe from this type of massive hemorrhage. You're not safe from persistent exudation because you could still leak from the non-polyp source, which is basically the BBN. Let's look at fluid. You'll see that the combination was very stable. Monotherapy was stable, but less so, less effective. And that's why very often the anti-VEGF doesn't completely dry the retina in cases of polypoidal. In terms of fluid-free retina, 17% were fluid-free with combination compared to under 50% monotherapy. And between Lucentis and the combination was better at reducing choroidal thickness. We did not compare this with aflibercept. So aflibercept is probably somewhere in between combination with Lucentis and Lucentis monotherapy. In terms of hemorrhage, very clearly it reduced hemorrhage. It did not induce hemorrhage. In terms of disease activity, you saw that with aflibercept monotherapy, very good. 90% were disease-free, or at least there were no active polyps at the end of 1 year. Here with combination therapy, 54% had no signs of activity versus 27% no signs of activity with monotherapy. So both functionally, structurally better. This is interesting. Time to first reoccurrence of disease activity, because this is what we are trying to achieve. Minimal number of treatments, hopefully with fewer visits, long-term maintenance of visual gain. And here you see with combination, mean reoccurrence was 270 days. 270 days from the time that you completed combination therapy. So that is actually quite reassuring to me that if I can close the polyps down, I have about 270 days before it might come back again. This is average, of course. This is the mean. And therefore, it is translated in reduced number of injections, right? Because you have initially given 3 injections with PDT. And the median number of injections was 4 over 12 months, meaning that you will need an additional 1 injection for the rest of the year. With Lucentis alone, it's 7 injections median, right? Which is what you would normally counsel patients. 50% with the combination did not require more than 1 injection above the loading dose. But if you gave Lucentis alone, a third of patients require almost monthly injections. So it's just another way of dicing it up. More treatment if you use monotherapy. Over 2 years, median of 6 injections in a combination compared to 12 injections in the randomized monotherapy group. So again, it's quite clear. Your treatment with injections will be reduced if you use combination as a first line. In terms of PDT, thankfully we didn't have to repeat the PDT over and over again. Right? We were worried about that because of atrophy. So the majority of patients, 1, at most 2 PDT over 2 years, which is quite reassuring. The retreatment algorithm is what I use in my own clinical practice. At 3 months after loading dose, I perform the ICGA again to determine whether or not I see polyps. Whether they're active or not, that's not important at that stage. Are there polyps or are there no polyps? If there are no polyps and there is disease activity, then the activity must come from the BBM. So you treat with anti-VEGF. If there are polyps and it's active, you treat combination again. If there are polyps, no disease activity, you watch. You watch closely because you expect disease to come back. So you probably have to see them almost monthly. The risk of atrophy is minimized when you repeat PDT. Don't treat the whole lesion. We call this selective PDT. For the primary lesion, I recommend treating the whole thing. So BVN plus polyps. Subsequently, you only treat active polyps because you are not going to do PDT monotherapy. I only use PDT to close the active polyps, the present polyps, and the rest of the exudation is controlled by anti-VEGF. So you don't need to keep treating the entire lesion with PDT. Why? Because the risk of atrophy doubles with the radius of treatment zone, R squared. The larger the treatment zone, the exponential increase in the risk of RPE atrophy. And people don't realize that. This is all done in animal studies. PDT is damaging when it's very large zone. My threshold is about 4,000 microns. Anything above 4,000 microns, I get a little bit nervous. Right? So anything less than 4,000, I'm fairly comfortable it's not going to cause that much damage. Anything greater than that, maybe you would think again. Treat active polyps alone, don't treat the entire lesion. If you have recurrence activity without polyps, and this is not uncommon in the later phase, the second phase of the disease, then you treat with anti-VEGF in the way that you would treat any choroidal neovascularization. Okay. So this is what we've learned actually from the retreatment in Everest 2. This is probably the most important lesson. If you keep hitting the entire lesion with PDT, of course you're going to lose vision over 3 years or 5 years. Then you've wasted all your efforts in trying to control polyps, but you've lost the game by functional loss. So if you want to harness the best of both worlds, use PDT sparingly and targeted, maybe at the polyps, and you use the anti-VEGF to suppress the negative effects of PDT, like post-PDT hemorrhage, post-PDT transudation. At the same time, you're controlling neovascularization and angiogenesis. Just a quick word about deferred PDT. So some people prefer starting with anti-VEGF and then adding PDT. We call this deferred PDT. It is a reasonable option. And this was proposed in Osaka, in the Fujisan study. The treatment schedule is you treat first with anti-VEGF, and then you consider whether they need PDT later. The criteria for PDT here was presence or absence of polyps, so it's different from PLANET. PLANET was rescue, so less than 20%, right? Here, about 50% still had polyps. It was deemed present and needed treatment. So you find that the variance in PDT rates was very, very different. And then they compared it with immediate combination. So clearly, you find that actually in terms of visual acuity, not much difference, at least in the first year. Not much difference. The only difference was really the number of injections, because you would have had to treat first with 3 injections and then decide later whether you needed to add PDT. So the group with deferred PDT needed more injections. So if your main consideration is treatment burden, visit burden, monitoring burden, then combination therapy may be preferable. If your main concern is you want to control visual acuity, you can choose both. Monotherapy or combination therapy judiciously. So I've come up with this practical approach. I hope you can give me feedback on whether you agree or disagree and whether you use it in your own. Right? Let's say you come from a low risk population. By low risk, I mean either Caucasian, non-Asian, non-Oriental. No suspicious features of PCV. What are they? Shout them out. What are the suspicious features of PCV? On the spectral domain, thumb-like protrusion, double layer sign, pigment epithelial detachments. Right? Other clinical features which are suspicious? Orange nodules, very good. Thick choroid, a lot of hemorrhage, right? A lot of hemorrhage. Unilateral disease. Pachydrusen. Younger. Very good. So you've got all your clinical features, suspicious features of PCV. But if they are absent, go ahead, start anti-VEGF monotherapy, because you're not going to do any harm to the patient, and the vision is going to improve. You need to control activation. Okay? If there is no morphological response after 3 injections, or if you choose 6 injections, that's fine, that's arbitrary, then you need an ICGA. And if polyps are present, we will consider doing combination. Quite practical. Then if you are in a high-risk population like in Singapore, Japan, Korea, maybe not a good idea, because about half of our patients who have underlying PCV, you might end up having to give a lot of injections over a short period of time. So high risk, usually we do ICG. I'm sure in Japan, almost every patient with wet AMD comes in with both ICG and FFA. Not every country does this, right? If PCV are present, you can choose, you can still choose between combination and monotherapy. Bearing in mind, you know monotherapy, you will need to see them more regularly, probably you have to do more injections. Right? Or if you choose combination therapy, you still have to see them at least monthly for the 6 months. But once they are close, you've got a bit of breathing space. I usually extend it to 3-month follow-up after that. If there's no response, no morphological response after, say, 3 injections, then I will add PDT. This is a deferred PDT, if you have chosen monotherapy as your first line. So this is quite flexible. I'm not saying that you have to use PDT all the time. I'm not saying that you have to do monotherapy all the time. Right? But there are some instances where I would not recommend adding PDT. And this is important too, because these are the situations where you might make things worse. When the visual acuity is very good, you don't need to rush into something that might cause a further deterioration of vision. Now, if you look at Everest 2, the patients who had 6/12 or better did not lose vision. But we don't know about 6/6, we don't know about 6/7.5 or 6/9. So that one you're on your own. I generally treat patients across the board, whether they come in at 6/6 vision or 6/12 vision. But the better their vision, the more likely I'm going to use reduced fluence, half fluence. But that's not evidence-based, right? I don't have data to say that it's safer or it's more effective. So if you're going to use a PDT protocol similar to Everest, then if you are 6/12 or better, you certainly don't know. 6/9 or better, because our recruitment was 6/12 onwards. We do not have definitive guidance on normal vision. So you can still start with anti-VEGF. I think it's reasonable. If they are pulsatile, non-pulsatile, small and simple, they often disappear on their own or with anti-VEGF. It is only the large clusters, string of pearls, large, juicy polyps. Those don't disappear with anti-VEGF. Watch out for the choroid. Remember the supporting actor. If the choroid is thin and there's already pre-existing RP atrophy, think again about PDT. Try and minimize it or use selective PDT when possible. When you're not sure, maybe mixed lesion or not so clear, not sure about polyps. Sometimes we call them micro polyps. Small little light bulbs in association with the branching vessel. So not definitive. We don't have the halo, we don't have pulsatility. So when you're not sure, assume that it's not and treat as CMV. Of course, I already mentioned when you have no polyps and the activity is coming from PVF, you treat with anti-VEGF. And when there's a lot of hemorrhage, you can't see anyway, blocking. Would you do displacement? That's very personal. I don't like to use displacement. Many people have good success with displacement, right? So I leave that up to you. But whatever it is, consider adding PDT. So what happened to our first case? After 3 injections, now the polyp complex getting bigger, fluid increasing, visual acuity about the same. At 6 months, still there, quite a large polyp, but vision has dropped to 6/24. Neurosensory fluid has increased. Then we add PDT. That's when the lesion settles. So this is a typical case. When you start with monotherapy, you don't get a good morphological response. Consider adding PDT. Right. So to summarize, regardless of ethnicity and geographical location, PCV is responsible for about 50% of anti-VEGF poor responders. We now have good evidence, thankfully, from a lot of RCTs, so both on the combination side as well as the monotherapy side. There are advantages to combination therapy that I told you about, mainly in reduced number of treatments, both injections and PDT, longer disease-free interval. But you have to couple that with the technical difficulties of doing PDT, knowing where to do PDT, knowing how to do PDT. Even when you start with anti-VEGF, at any time you can add PDT when you feel that things are not going the way that you expect. So I hope that has given you some clarity as to what to choose when for PCV. Okay, thank you very much. Let's have a few minutes for questions, and then we have a photo before tea. Anyone?
Sir, excellent talk to you. And I have 2 questions. One question is pretty basic, and maybe I didn't understand it well. One is like you said that it's more in the oriental populations that we see the polypoidal vasculopathy. Now we know by so many studies that myopia is more common in these populations again. Myopia is a disease where the choroid will be thinner, and this disease is linked to pachychoroid. So how do you explain that it is having a pachychoroid?
My answer is that myopia is protective against many things.
Yes, it is.
It's horrible to have it on its own, right? You have all these macular complications of myopia. But high myopia, pathologic myopia, is protective against PCV, it's protective against central serous. In fact, it's also protective against diabetic retinopathy. If you notice, most of your patients with high myopia, they don't develop severe diabetic retinopathy because probably everything is so attenuated anyway. The amount of VEGF that you produce is very, very low. And so there is, in a way, some fairness. So the people who get polypoidal are very often low to moderate myopes. They are not high myopes.
Let me put it the reverse way. The population which has got lesser myopia, say Indians,
Yes.
Do not have so much of PCV. So that means there is some kind of racial predilection to this disease.
I believe that the racial predilection is in the pachychoroid. So the conundrum is in the pachychoroid and how pachychoroid comes about. You know, Professor Takahashi will probably have better ideas than I do, but that is the fundamental question. What is the genetic risk causing or leading to pachychoroid. If we can find that link, then we can explain differences in various populations. Because I think if you were to do a survey of choroidal thickness in the Indian population, you'll find that pachychoroid is less common. Is that correct for those of you who have done?
Forgive me, Professor Takahashi, if I'm crossing the line, but the point here was that we end up somehow of late with the newer modalities of OCT diagnosing more PCV than it was being diagnosed before.
Sure.
Now, the analogy can be drawn to the time of FFA when there was classic CNV, occult CNV based on FFA, and then the diagnosis and the prognosis was made predominantly classic, predominantly occult, the results will be accordingly. So sometimes what happens in my kind of institute where I was working, we see one polyp and we label it as a PCV. We do not look that it may be a predominantly an occult CNVM with one polyp. And these patients may end up responding much better to anti-VEGF than going with a combination therapy. So should the classification be based on the predominantly a PCV or predominantly BVN and more or lesser of a single polyp, something like that? So will it be more helpful in
maybe
the
we can
treatment?
invite Professor Takahashi to give a comment. Just to preface that, in fact, in Japan, Professor Yuzawa had proposed a classification based on exactly what you're saying, polypoidal CNV versus true polyps,
Exactly.
right? So it has not really caught on internationally and universally because it's too confusing and most of us are not great readers of ICGA. So we found that classification was difficult to adhere to, but I would like to hear Professor Takahashi's view on that.
I think the very simple point that small size is very effective for the PDT. But in the big round, radiating BVN and with the many polyps tend to be hypervascular PD after PDT. So that, I think that the efficacy of the PDT is more effective for very small polyp and single polyp. I don't know that genetic problem is related to the responsibility of the PDT.
I know there's several groups in India now looking at pachychoroid, so it'll be interesting actually to look at their findings and their observations. I don't know of any particular genotype, Takashi, Kanji, if you can correct me if I'm wrong, I don't know of any genotype that currently confers risk to the pachychoroid spectrum. I don't know whether or not it's indeed accurate to say it's pachychoroid that's causing this in the first place, but the observation that the choroid is thicker in people with PCV and CNV has not been explained genotypically.
Yeah.
Thank you. Thank you.
Sir,
Yes.
in patients of PCV who have a huge ED,
Yeah.
it has been found that there is an RP rip,
Yeah.
which is during the course of the treatment. So what do you feel? Is it due to the aggressive anti-VEGF treatment or it is the natural course of the disease? And is there any way to prevent this RP rip happening?
The answer is no, we don't have a way of predicting or preventing RPE rip. The larger the RPE, the RPED, the higher the risk, so you just have to tell patients that whether it's on its own or whether it's induced by treatment, I can't really tell. There have been papers trying to look at vector forces, how these vessels, when they contract, pull on the underside of the RPE. All this is hypothesis. But what I can tell you is in large series with eflibercept, with ranibizumab, and with combination therapy, both Everest and Planet, we did not see excessive rates of RIP. In fact, we had 0 RIP in the combination group. We would expect that a combination of an anti-VEGF with PDT action might actually induce more RIP. So I think maybe the risk of RIP may be overstated. Yes, it is present. It could happen spontaneously. But I don't think it is necessarily caused by aggressive injections or even combination therapy. I can't tell you how to prevent it. Neil?
I can't prevent it, but I think of it in this way. Let's make believe
let's make believe it does increase the risk of tear. Look at the outcome of treatment versus no treatment. 40% improved vision versus near 0% improved vision. So I'd rather have the risk of a rip and a 40% chance of improved vision. So it would be nice to identify ways of preventing it. We don't know how, but we do know that the vision is far better if you treat than if you don't. So I would, with somebody who has a large PED, say your vision might drop because this could tear. Your vision may not drop even if it tears. I wouldn't stop treating someone if they still have VEGF activity and it tore. I would keep treating them right away. We have no evidence that that outcome is going to be worse. We do have evidence that if you don't treat, the outcome's worse. And so that's how it goes. I warn people that don't have rips. They have a 10% chance of losing vision when we're very meticulous about our treatment, 10% chance. So that's how it goes. So as you said, it would be great to identify why that happens, but it does not stop me from treating.
Okay?
So,
Oh, sorry, yes.
when I asked you about questions relating to complication of PCV, does it break through vitreous hemorrhage? So, first question, what is the mechanism of breakthrough vitreous hemorrhage? And second question, should we indicate from vitrectomy or delayed vitrectomy? And the last question concerning about hypema, rare but serious complication after vitrectomy. So how we can prevent hypema?
So the mechanism is largely mechanical. If you have a sudden rupture of a polyp or many polyps in the subretinal space, that blood has to find its way somewhere, and the path of least resistance is often the fovea. Right? So you'll find that a lot of times when you have breakthrough hemorrhage, the fovea is the one that suffers. Rarely, if you're lucky, it's extrafoveal or extramacular. So the point at which it is broken through would probably be badly affected, badly destroyed. And so when you are faced with breakthrough hemorrhage and you have no view of the retina, you can do a B scan, you might know roughly where the thickest point is, but you can't really tell where the point of breakthrough is. So you tell patients that the outcome will depend on where the blood had broken through. But I think it's largely mechanical, right? What do you do? Do you want to take it out immediately or do you wait? Most of us will wait. We will try and calm the whole complex down, because going in when it's hot probably would end up with problems with post-vitrectomy hemorrhage. I always check for bleeding diastasis in these patients. Do they have any risk factors for massive hemorrhage? We've picked up patients with asymptomatic thrombocytopenia. We had one patient with aplastic anemia, didn't know it. Right? Another patient didn't tell us, but he was on anticoagulants, or maybe the patient himself didn't know. Right? So I think these are factors that you have to bear in mind. Do they have any bleeding diastasis, which would make surgery dangerous anyway? Okay. If the hemorrhage is so dense that you have no view of the retina, the first thing we have to exclude is a retinal detachment. If there is no retinal detachment, you can afford to wait. But that waiting can be years. I have patients who take 6 months, a year, before the macula can be visualized. And that's often unacceptable to most patients, right? I usually continue injection until I see alteration of blood. So, for example, when you look at the retinal lentil space, you see fresh blood, and of course, I think there's probably still a source of bleeding. But once you have an alteration in color and they start becoming dehemoglobinized, you can probably stop. It's very fluid at that stage. I have a discussion from day one about early vitrectomy versus late vitrectomy. My preference is to wait at least a month, 2 months before we go in, because I'm not planning to drain subretinal blood. In the early days, we thought by draining subretinal blood, put TPA and so on, you would end up with better outcomes. Not necessarily. You end up tearing RPE out and ending up with huge areas of atrophy. So we are not into immediate vitrectomy, unless it's the only eye and he can't work and can't navigate. So with delayed vitrectomy, the question is when, right? If there's significant improvement over 4 weeks, 6 weeks, 8 weeks, you wait. But if it's very, very slow and the blood is still not clearing sufficiently, you would start talking to the patient about vitrectomy at about 3-4 weeks after the event. I don't have a definite way of managing it. Now, when you remove the blood, it's very important to assess carefully where it came from. And very often it gives us an opportunity to do a post-op ICG to see if there are any residual polyps. If there are no residual polyps, then you don't need to treat. The issue of silicone oil is controversial. Some people believe that it stops future recurrence, others don't. I don't know about Kanji, but we generally don't use silicone oil unless there's an iatrogenic break or there's hemorrhage that we can control on the table. So silicone oil has its problems, right? If you have to treat later with an anti-VEGF, let's say, are you overexposing? Is it safe to do anti-VEGF? All these issues are unknown at the moment, right? So yes, it's a rare occurrence, and I think a lot of it depends on your personal preference. Yes, quick one.
We often experience large submacular hemorrhage. You said you are not convinced with the intravenous gas displacement. So what else?
So some people like to displace the gas, do ICG, and then treat the polyps, right? If you can do that when the hemorrhage is fresh, maybe that's a good idea. But very often the patients I get are quite late. So by the time they come to me, they're about 2-3 weeks down the road. Maybe you're not going to get much displacement anyway. Right? So if you get them very fresh, yes, you can consider displacement. Right? You can push it away. Hopefully, even if it breaks through, it doesn't break through to the fovea. But I've seen retinal detachment from gas. Patients who come to me from overseas cannot fly back. So there are a lot of disadvantages, to intraocular gas displacement and TPA. TPA is also very difficult to store. For us, it's only found in big facilities. It's very expensive. Right? So if you're a big hospital, yes, you have TPA readily available. So for these practical reasons, I don't use it often, but I know that many people do, and with good success rates. Okay, we have got to postpone some of the questions. I can take them later on. But let's have a quick photograph before tea, all right? Cindy, can you organize? Just come to this side of the room.